Hello, everyone, and welcome to our November 2024 edition of our free Q&A. And I wanted to thank everyone again for your participation and sending in some great questions. And Cindy, how are you today? And are you ready and excited about all these questions and having to do with a lot about the GG items?
I noticed that. So I'm excited about today's conversation, not only for the ones that were submitted in advance, but for ones that people get inspired to send in via the chat box. Or if you're listening to the recorded version, you have an email way to get a hold of both of us and let us know what you're thinking.
Okay, here comes question number one. Is there CMS guidance for doing a SCIC or other follow-up? SCIC is the old thing, significant change in care was what that stood for. But Cindy, what are the guidelines around that? If you can, we've had this one come in several times.
Okay. Well, actually, it's a significant change in condition, and the only guidelines we're given is that if the patient has an unexpected decline or an unexpected improvement, then we can complete a follow-up OASIS to essentially reset some baseline issues related to quality metrics. Now, I've always thought that that was kind of amusing in terms of I totally understand that if the patient has an unexpected significant decline, I would want to be able to capture that. And that would really be in a situation where it didn't cause a hospitalization, because we know if that decline precipitated, they went to the hospital and were admitted, then we'd be dealing with a transfer and a resumption, and that would all factor in from a quality standpoint. But if this was a significant decline that didn't trigger any other OASIS time point, then we have the option to do it. But to also say that if the patient unexpectedly improves, you would want to do the same thing. I get it from covering all of your bases, but in my 30th year in the home health space, I have never heard of anybody filling one out because of an unexpected improvement.
Yeah, that was always the funny part of that, right? That reg is that if you have someone go in the hospital and have an unexpected change in their condition, like a surgery or an infection or something like that, it makes sense to redo and do a SCIC, and that way you have better reimbursement on the tail end of the episode. However, like you said, that you're supposed to also send in for those improvements by the letter of the law, although I don't know if the spirit of the law is there, because like you
Well, and I think the key issue there, Sherry, is unanticipated
yes.
significant change. So that's why I'm very comfortable outside of those general parameters. They don't give you specific, if this happens, then you must. They pretty much leave it then to the organization to look at that patient situation and say, is this significant enough either way that we're going to go ahead and complete this? And yes, I see things coming in. Yes, it is taken into consideration as part of looking at outcome measures. That's why they give us that option to be able to essentially reset some of the baselines. So again, I'm not saying every time somebody has a decline, we should do it. It needs to be looked at is it significant enough in terms of OASIS data measurements to go ahead and complete it and submit it.
Okay, I'm getting some messages that my mic is not very great. Cindy, can you hear me okay?
It's a little better now. It was a little quieter at the beginning.
Okay, and if I get any other messages, I will continue to increase the volume. I just don't want to blow everybody's eardrums out. I have a question that came in, Cindy, on this same subject. Does the SCIC really reset the bar for outcomes?
Yep, that's why I made that comment, because I saw Linda's thing come in through the chat box.
Okay.
That's why there's value to it. But again, you want to look at it from a individual patient perspective of does it change enough to warrant doing it? So we don't see a lot of them being done very often. And like I said, I've never, if somebody's seen one, I'd be very curious to know what would make someone do that for unexpected improvement.
Okay. Second question is pretty involved, Cindy. That was a straightforward one. I was just warming you up for that one. The second question is about the social determinants of health, and I'm putting this one into the chat. So you're welcome to take a picture of it or copy and paste it onto a sheet of paper. But when you get the recording, you should be able to see the chat box and see the questions that are asked. So this one's on social determinants of health. I'm trying to get a definitive answer for the following scenario. If a patient is alert and oriented but unable to speak and understand the English language, an interpreter must be provided to interpret and relay the patient's response. The guidance is telling us to select X in addition to the interpreted patient response when pertaining to A1001 ethnicity and B1300 health literacy. Is the patient considered unable to respond in those situations where they have to use an interpreter?
Okay, so when we look at any context in OASIS with the issue of being unable to respond, we see it in the BIMS, the very lead-in question for the BIMS. We see it in connection with the PHQ 2 to 9, and they are consistent in identifying unable to respond is that we have exhausted every means possible and cannot understand this individual. So it could be verbal, it could be in writing, it could be, whatever we've done, we have tried every way and we are unable to understand what this person is telling us. Use of interpreter is allowing us to understand what they're saying. So if I didn't get it verbally, I can't get it in writing, but the interpreter is facilitating that they are able to communicate with me, then I would not be leaning toward the unable to respond answer. Now, if I'm in a situation where I recognize that an interpreter is really the only mechanism and there is no interpreter at the time of the visit, then the inclination would be that the patient is unable to respond, and I would be documenting what the issue is related to the interpreter. What's interesting, Sherry, is I had a call with our review team just a couple hours ago, and one of our OASIS reviewers was saying that he's noticed more than an isolated occurrence where the documentation in the record states that the patient requires an interpreter, that there's really no way to understand this individual other than that. Goes on to say there was no interpreter present during this assessment visit, and then answers all of the OASIS questions with answers that indicate the patient was interacting with the clinician. So that would definitely, by extension, related to the question we were asked, raise questions about, wait a minute, you just documented that you cannot understand them at all unless there's an interpreter, and there was no interpreter. So on the flip side, how did you get answers to all of these questions when there was no interpreter present? And adding to that, I've seen when I audit charts, a start of care clearly documenting that the patient requires an interpreter. The interpreter was present during that assessment visit, but then other disciplines come out and it's hit or miss whether they mention the need for an interpreter, or they'll even in some visits interpreter's not present, and apparently it has no impact on the visit. The visit looks just as comprehensive as when the interpreter is there. So I think we do, in this interpreter situation, need to look at not just how does that impact an OASIS answer, but how am I documenting it and how am I managing that throughout the course of the episode? Because we know that if the patient requires an interpreter and this individual is inconsistently there, that is potentially going to affect the effectiveness of our care plan. And you want to own that throughout the course of care in your documentation, because that is a unique patient situation that could be complicating what's going on with them going forward. So again, just an interpreter, if I can use that interpreter and using that interpreter, I can understand. So I ask the patient the question, they translate it, the patient gives it back to me, then I would not be choosing that the patient is unable to respond.
And the same thing goes for things like being hard of hearing or difficult to understand. If the patient has a speech impediment, like a aphasia of some kind or any of those kinds of things, you'd want to see that consistently documented through the note and through the notes and be something that is impactful to the care, because 9 times out of 10, that difficulty hearing and that difficulty communicating can make or break a plan of care. So I think it's super important, like you said, Cindy, that it has to be consistently documented throughout the record.
Well, and two quick things with that, Sherry. One is this is why, and I'm still kind of shocked that we're this far into E, that we're about to go into OASIS E1, and we still find clinicians on that first question for the BIMS putting down no, that the patient is rarely or never understood. And then they ask them all the other questions that were listed in that question you asked me, ethnicity, race, language. They can answer all of those, but they couldn't answer. You couldn't understand them well enough to do the BIMS, but you got all the rest of it. That doesn't make any sense. But you're right. I think things like hearing impaired, cognitive issues, I think we're very focused on capturing them on an assessment, but not very good at saying how those complications affect our care delivery and how much skill it takes. That teaching someone with those issues in play or combination of those issues can be much more difficult. And my skill is in navigating that and ensuring we achieve the best possible outcome under those circumstances. I see a lot of documentation of cognitive and visual and those kinds of things, and yet all the visit notes are just teaching, 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 and they read identical to teaching someone you didn't identify had that. So I think sometimes we do that. I mean, overwhelmingly, I believe we do that in the home, but we're not giving ourselves credit in the documentation in that record.
100%. Okay, so the next question was shouted at me, so I'm going to put it up so I can show everyone what it looked like when I received it. I have a question. Should I shout it back? In reference to a TIF or no TIF for a Q&A, I was informed that a TIF is not required unless the patient stay is greater than 2 midnights. I understand the 48-hour time frame for completion of a TIF OASIS, but I've never heard this one. Our patient was sent to the ER, was assessed, and then admitted to a hospital room. Patient was released the following day, being greater than 24 and maybe 24 hours and 20 minutes. Cindy, what is the rule on that?
Okay. So first of all, we have to peel the onion a bit in terms of the transfer to an inpatient facility. Yes, they went to a hospital. Yes, they ended up in a hospital room. We still have to vet, were they actually admitted? Because I still see a lot of this, and there's other questions I get asked. And when you dive into this scenario, the person was kept in observation status. The minute we know, and it doesn't matter how long they've been there, we see evidence of people that have been in the hospital 5 days, 7 days, and were kept in observation status the entire time. When that is the case, you cannot complete a transfer to an inpatient facility because technically speaking, they were never transferred because they were never admitted. And that's a whole other conversation we could go down with respect to, but they were out of our possession. They had tests, they had interventions, they had all this other stuff go on. Yeah, I know. And it does mess with our data and it messes with other things like potentially a transfer to a skilled nursing facility. But if that individual, no matter how long they were there, remained in observation status, the transfer cannot be completed and submitted. They technically were not. So to the context of, does it have to be 2 nights? No. They have to be actually admitted, and it cannot be for routine testing. So that's the exception we've had in play forever, basically, that going in for routine testing less than 24 hours like that is not considered an actual transfer to the hospital. And that usually is not a routine occurrence. But the whole 2 nights isn't the issue. It's confirming that they were actually admitted and they were admitted for a medically related reason that needed to be treated, not for routine testing.
Okay, there's another question about this. What if the cert runs out when they are in observation?
You know, that's always a tough situation because the answer never makes anybody happy. It is not considered a transfer to an inpatient facility. And so we run into a situation where we're out of the recert window. They did not come back. We do not have a transfer to go back to because we know if they were admitted near the end of a cert period and we did a transfer without a discharge and the cert period lapsed, all we have to do is document that they, did not return in the cert period and we wrap this up and then we readmit them when they come back. This just takes documentation with respect to the current situation is that they were not transferred to an inpatient facility. And then what I've seen is the recommendation being to complete that recertification as soon as possible when they return to the home. Yes, it messes up dates. Yes, it causes problems. And one of those biggest beefs is it's not our fault. They clearly went to the hospital. There was nothing I could do about it. I can't go in there and do a recert. I can't make them send them home. So it's a workaround. But I strongly encourage when we get frustrated about the whole observation status, there's a lot of work being done by Medicare advocacy groups and trying to, work hard to fix this because it causes a multitude of issues, not just for home health. So however we can get into comment periods or support letters or be aware of efforts to address this and lending our voices to it, it really is something that doesn't make sense that a person is kept there for days and not technically admitted, although we do know why, because that helps to manage a hospital's readmission rate, because it also doesn't count as an admission for them either. And
And
yes, I see what's coming in, Sherry, about the admitted for 20 more than 24 hours. Yes, it's related to more than 24 hours, and the issue being not for just routine testing or medical related testing.
And Cindy, I'm gonna switch slides here because we have some things that we wanted to share with folks, because we do have a new Oasis version coming up starting January 1, and we've seen a ton of educational opportunities out in in our space, in the consulting space, and they're super expensive. And so we made one, when we look at it, we made one about what the changes are. Very simple, $79 for the entire agency, because we just don't feel like this is a big change this year, and we think that there's a way that you guys can do this in an expedited, inexpensive way. And so we took the time to put this together, and it's priced per agency, super easy, super quick, can get it out to all your staff. Cindy, can you want to mention that just a couple seconds ago?
Well, yeah, because we kept it to 30 minutes.
Yes.
We know every time there's a change and a number or a letter gets added, it becomes, oh my gosh, what's going on? We have to deal with it's a January 1 start date, which means training needs to happen during the best time of the year when there's umpteen holidays and staffing problems and referral sources that never remember your name suddenly do this time of year. The idea of pulling people out to spend hours reviewing information, if they really don't know what they're doing, that's fine. But a lot of folks just need essentially a booster shot of what's new, what's changed, what do I got to know to move on, which is why we wanted to put that together.
Okay, so use the QR code on the screen, or use the link at the bottom, however you want to. If you have any questions about it, you can reach out to us via the information on the last slide. Cindy, we had a question come in, and I wanted to add it to the list sooner than later, because it's a earlier Oasis point than the next question. So if a patient is determined to be safer transferring, hang on, I'm gonna add it to the text here, with rolling walker and supervision at start of care, resumption of care, but because of Alzheimer's forgets to use the rolling walker, how do we answer M1850?
The issue of answering any of those functionally related questions, whether they're the 1800s or the GGs, has to do with patient safety. And you have to look at that and say, okay, yes, you should be using this piece of equipment, and when you use it, you're doing better, but you don't consistently use it. You don't remember to use it. And so someone needs to be involved to remind you to use it, to put it in front of you to use it. Then definitely there is a higher level of involvement of somebody else to ensure their safety. So although you may say, well, if they have this walker, they'd be great. And we've seen multiple examples in 1860 over the years along those same lines. I know we're talking about 1850, but 1860 with respect to, looking at this holistically, if they should be using equipment, but they don't, if they should be using equipment and they don't have it. So the equipment in and of itself isn't what defines the answer. I would say if you're looking at it in terms of they're using the walker, and they need someone to remind them to use the walker, we know that the presence of someone and something puts them at a response 2 and not a response 1. So it may be once they've got the walker, they're tootling around and they look really good, but there's a significant percentage of the time they don't remember to do that someone has to be involved to make sure that they do it. Now we're looking at a 2 and not a 1.
And I think that it's super important that agencies take this opportunity to work on their interdisciplinary communication and have all the disciplines that go into the house remind that individual and that individual's caregiver that they should be using the assistive device. Many times we hear and read about folks coming to the door without the assistive device when it's not the therapist, and consistently not following the therapy recommendations for safety. And the other disciplines just kind of go, oh, well, not my circus, not my monkeys, right? And it's everybody's monkey and everybody's circus. So it's super important that you train your folks to get together and work together and make sure that if it's a nursing intervention, therapists can check up on it when it's super important, and vice versa. If it's a therapy intervention, nursing can check up on it and then inform the therapist whether or not they're following the guidelines. I think that that's something that we dearly need in home health, and it's an efficiency thing, and it's definitely a plan of care thing to get folks towards their outcomes.
I also think the other thing, whenever we're talking about cognitive complications to these, I think we're looking at it and saying, well, it's transferring, it's mobility, that must be, a PT thing. I think depending on where they are in that Alzheimer's disease process or any other cognitive issue, even a consult visit from OT and or speech could help to troubleshoot what is the most effective way to create reminders for when maybe I'm not physically there to do it. So does it need to be color coded? Do there need to be pictures hung up that trigger a reminder to use it? Is there a specific placement issue? I think sometimes, from the PT side, we can get very much into, well, all it would take is a reminder and then they're fine. But have we worked collaboratively to figure out, is there a better way to do this than just telling you to remember? I've seen a lot of positive outcomes of folks that needed help, whether it was medications or self-care related issues, by OT coming in and doing color coding, doing large pictures stuck to certain areas so people would remember where things were and could find it, and really figuring out what reminders work best for that individual. So I think anytime we're saying, well, there's a cognitive complication to this, well, it just is what it is. We may have members of the team that don't come in and fix it, but can give us some insights into a more effective way to help the person remember as much as they possibly can.
Exactly. And here's the reason why I put that question there, because we are on question 6 and we have our first GG item and it's related to 1860. So I wanted to stay in order as much as I could. On M1860, if GG0170N and O are coded as 4 for supervision because patient tells clinician that her daughter walks behind her for safety on the daughter's stairwells when she goes in the house for visits, but she is independent with a cane at her home where she doesn't have stairs. So she does not encounter stairs within her routine living environment. Would 1860 be 1, independent with a one-handed device, or 2, because GGs reflect the need for supervision on stairs? Also, the documentation is often not that detailed, so we come across GGs for stairs as 4, but documentation only says independent with cane for ambulation and doesn't clarify if the stairs are with the same environment or not.
Okay, so that actually is 2 questions. So let's start with the bottom part first, which would be documentation is key. When I review OASIS and I'm seeing, 4s over there on the stairs and then an attempt to put a 1 in ambulation and no clarity about where these stairs are or how often this person is engaging with them, yes, the expectation that I've clarified this, and it doesn't have to be War and Peace, but that additional documentation to support it helps to defend why those responses were chosen. Okay, so yes, there should be more documentation. Just saying it's not that detailed, I don't think it has to be a therapist to detail whether or not those stairs are in their home or you're referring to stairs at their daughter's. When we talk about 1860, it is what the patient routinely encounters in their environment. So if it's the occasional visit to the daughter who has stairs and she has to help me, that would not be a factor on 1860. Because that is not where they live. They don't routinely deal with it. Now, if it was, let's say, they were going to the daughters daily, because the daughter, that's where the daughter prefers them to be during the day and watches over them, and it's a very routine occurrence, then I would say that the daughter's stairs do factor into 1860. My clarifier, and that's strictly saying it would be a 1 in 1860 based on exactly how this question was submitted, stating that they are independent on surfaces with a cane. What I just want to put in as a tidbit is we need to be extremely careful about that word independent, because independent means that this person is completely safe and able. They are magnificent as the task is described. There is absolutely no concern whatsoever. They can do this activity 2 o'clock in the afternoon, 2 o'clock in the morning. You are blessing them as that clinician choosing the response, that they have reached the pinnacle of performance of that task, and you will not be putting it in your plan of care. You will not be ordering other disciplines. You will not be revisiting it again unless something goes terribly wrong. Now, some may say, well, that's an awful lot of words for, yeah, because I think we're forgetting what independent is. Patients may say, I do this by myself. I live alone and I use a cane. Doing something on your own and doing something independently are not interchangeable. On your own, yep, that's a statement. Independent is a blessing that the clinician has said, yep, you do it on your own, and I think you're fabulous. So if we have a person who you're saying when I go to see my daughter that she's got to be right there on the stairs, okay, that could be because you don't have stairs and you don't do them often. It could be because the daughter's a bit of a worrywart and wants to be there in case. But I would still revisit you're saying they're a one, particularly at the start of care, and this individual, although they don't have stairs in their home, just got out of the hospital or nursing home or was a community-based referral, so something went wrong, and that's why they got referred to home care. You're qualifying them as homebound overwhelmingly off a mobility-related issue, and I'm looking at your fall risk assessment, and they failed it. So between those three things, do you really think they don't need to be at least supervised on the day of the assessment when they're up and walking? I think it's a question you would have to ask because I'm a little hesitant on that description alone to say, yeah, that person should be a one because they don't have stairs in their house. I'd be digging a little bit deeper into the safety issue. And what did my fall risk tell me? And how are they homebound if this is a start of care? Before I'd say one is definitively the best possible answer.
Well, while we're still in the 1800s, we just had another question come in, so I'm not going to let you off the 1800s just yet. The 1840, in 1840, toilet transfer is tripping up a lot of clinicians and reviewers, just verifying that if the patient is able to get to the bathroom and transfer on and off the toilet, regardless of how much assist, min, mod, max, the answer is one. If completely independent, ambulating to toilet and transfer on and off, then a zero. If the patient is not using toilet and needs commode, urinal, bedpan, and equipment not at home at the time of assessment, need to downgrade.
Okay, so one of the biggest issues I have when you look at the 1800s versus the GGs is the GGs finally got us to a standardized scoring guide. So whatever the task is listed in GG 130 or GG 170, we know that the scoring guide is consistent. The challenge of the 1800s is the inconsistency in the response options. There's some similarity in flow, like with grooming, upper body dressing, lower body dressing, and toileting hygiene, but a lot of them, and toileting is one of them that kind of comes out of left field with it's still zeros, ones, twos, and such, but it isn't the same as zeros, ones, and twos in other questions. So the question asker is correct that it is the complete task of getting to the toilet, on the toilet, off the toilet, and back out of the location the toilet is in order to complete that task. And if they are doing every element without any safety concern whatsoever, that's how you're a zero. But we see that in that response one, that supervision and assistance, thank you, OASIS discipline neutral data collection, puts a lot of that stuff together, which we rationally, clinically would never put that stuff together because they can vary widely. No, that one does say supervised, reminded, or assisted. Yeah, it does get into if there's pieces of equipment, urinals and bedside commodes that they're using, that's what those responses are for. But that often leads to confusion about the dependent option. Not in the person that can't absolutely do anything related to this on their own. We figure that out. But there are safety issues we have to consider. So it's been asked several times to CMS the equivalent of if someone picks them up and carries them to the toilet and puts them on the toilet and then carries them back. Is that are they doing it no, that is considered dependent because the person is being carried to and from the toilet. So when we've reached a point of intensive assistance like that, then we have moved beyond the one that includes the supervision and reminder. My big thing that I end up pointing out in OASIS auditing has to do with choosing bedside commode responses and providing no evidence the bedside commode is in the home. I think that's some of the trip up I'm seeing is, okay, I get it what a zero is. A one sounds like a little bit of help. Well, I think this person needs more help than a one. So now I've picked two saying bedside commode. Okay, but I look under equipment, I look in your narrative, I look in nowhere. Do they have a bedside commode? And there's no evidence you ordered one. So your response of a bedside commode is not defended in the documentation. So I think sometimes that frustration with, I don't like that response, because, it's more than just reminding your supervised, you can't create your own definition of a response. If you're going with bedside commode, there should be evidence that a bedside commode is present. If you are ordering one based on your assessment, it also says in the guidance, you are not obligated to only choose the bedside commode response. If it's not there yet, and you're not even sure that in and of itself would fix the situation, you can consider that dependent and toileting response from a safety perspective.
And I think that we need to take this moment because we have some other ones coming up to recommend that folks look at what their policies are and how they train their clinicians to answer these questions, because Cindy and I do a lot of audits and a lot of reviews on a daily basis, and we consistently see these being one of the two choices. They're either marked as too dependent or they're marked as too independent. And for some reason, there's a lot of disconnect with these functional items after 20 plus years, right, Cindy? Where we can definitely see that there's some manipulation going on, and we would warn heavily against that, especially coming into 2025 with the payments changing due to VPP.
Well, and I do understand when we look at particularly the 1800s through the lens of outcomes. And I know that the toileting isn't in Care, Compare, or Stars, but there's a frustration with that item because if you're putting supervision and assistance all together and I choose that, the only way I can show that I've improved that situation is to get them completely away from any form of human assistance. Whereas in the GGs, we could move someone from starting out needing, physical assistance to ending up with only supervision and be able to delineate, yep, there's a change. They still need some help, but it's nearly not as much. The toileting question has caused a lot of frustration because of that. And I think that facilitates well, then I'm going to choose a 3 because, choose the bedside commode answer because I feel like that's more representative of them needing more help. This is where we always have to go back to the guidance. We don't have to love it. We don't have to think it's the best thing ever, but we have to make sure that we are following the instructions we've been given. And I see there's been several shout outs in the chat, Sherry, about please list the bedside commode.
Yes.
Yeah, that's something. It's our reviewers send that back with regularity. It's like, I'm not going to change your answer to something else, but please review this because I can't find any evidence of a bedside commode.
And that's super important. If they're still using a bedside commode, that by itself implies a certain level of debility, right? And so having all the equipment that is necessary in the home for that person to stay safely at home, list it all and put it on there, and it paints a better picture of what the patient is going through and the limitations that they have at home. So I think that we as an industry need to get better at that, and we need to be really careful using artificial intelligence and allowing our clinicians to use artificial intelligence. And just a little disclaimer here, they're using it whether you know it or not. It's kind of like maintenance, right, Cindy? They're doing maintenance whether you know it or not. Clinicians have discovered AI, they've discovered Dragon Notes, they've discovered talk to text. The important thing there is that you edit it and include and add all the things that are missing when you do a talk to text or how the machine mishears you. So this is super important when you're talking about these functional items, that you have that equipment listed and that you list those impairments throughout your documentation, not saying it that you repeat it, but that it shows up as being integral to the care that the patient's receiving. There has to be a match, right, Cindy?
Yep.
Okay, so now the next one, we have another question. Where do you suggest education should start now? We still need to do the education for the M1800s in full, but also the GGs. And this individual has started with the reinforcement of the 1800s. Cindy, can you give your sound advice to agencies that are looking at, the GGs are now going to become our outcomes? How would you recommend this be trained?
Okay, so first of all, I want to put front and center that we did not coerce that question or tee up that question because my answer, Sherry doesn't have a QR code for. We already have a pre-recorded webinar specifically about the GGs. I think that we have to be cautious in terms of they are not brand new questions. Maybe they didn't get as much attention as they should have from an educational or a review standpoint. But I think the reality is a lot of these tasks are already being assessed in terms of the counterparts in the 1800s. What I have been suggesting, especially in situations where you're trying to look at both, is the time has come to integrate the training.
Yep.
To say, if I'm going to talk about upper body dressing in the M1800s, then I am also going to talk about the GG counterpart. Yes, 1860 is one isolated question about ambulation. GG 170 has a multitude of things in there of 10 feet and turning and 150 feet and stairs and picking objects off the floor. I think we need to shift our educational focus to an integrated model. K&K has been doing that for a while now. I push very hard to say if we're going to talk about the 1800s, we're talking about the GGs. They really shouldn't be separated. We did a standalone GG discussion, but still threw in 1800s into that webinar as well, because what I'm concerned about leading up to January 1 is that a lot of reviews we've done at K&K, you can tell agencies have been focused on the 1800s. And so we see, that they're being coded appropriately and indicate that they are needing assistance. And then in that very same document, the GGs are loaded with 6s and 5s, which say the patient is independent and magnificent, or they are magnificent as long as somebody hands them something first and walks away. This is basically setup or cleanup. The task is equally as independent as a 5 and magnificent as a 6. Both of them are absolutely pinnacle of performance. The only difference with a 5 is somebody had to do something before or after the task. But during the task, walked away delighted that this person didn't need help. So when in that same document you have that inconsistency, we have to think about it like the payer thinks about it and keeps calling it a behavioral adjustment because they think we're being naughty. So it may be I just wasn't paying attention, but if I in the same document have aggressive 1800s and more passive, you're really okay GGs, someone could very easily interpret that as gaming. That you were going after the 1800s because of outcomes, because of PDGM. That being said, it's now late November. I'm trying to get my staff better on top of the GGs, and we may notice some changes in scoring. I would anticipate some adjustments in scoring, especially for new staff, to really understand that those response options, although they look clinical, OASIS is not. It's discipline neutral data collection. I know those GG responses are not clinical because no therapist in their right mind would ever use the term touching assistance, which is included in response 4. It would never fly. Patient is bathing with touching assistance, they'd call the cops. So these are discipline neutral data elements. Newer people, okay, maybe I didn't quite understand, maybe I didn't pay attention to the fact that a patient who needs 2 people to help them is considered dependent. Even if one of them is just doing verbal cues and the other one is hands-on, if it involves 2 people, the definition by those response options is dependent. What I want people to be careful of in their prep is 2 things. One, there's a lot of discussion right now, and some of you have already heard this, so I won't belabor the point, of saying we shall no longer use the activity non-attempted codes. Don't use them, don't use them, don't use them. Okay, the bottom line is they are a bit of a complication in predicting that discharge score, that they're going to use magic math to impugn the values of those, which mind-blowing, but regardless. Do I think that we were a little freewheeling with the ANA codes prior? Of yes, we were staring at the 1800s and they answered those and we're very glad and we're making sure those are right, but didn't really call them out for all the refused, not attempted stuff ending up in the GGs. Because having seen the data, being part of the technical expert panel, it's pretty routine to see not attempted codes coming out of home health. So if it's been a routine occurrence, and in 2025, we stop dead and don't use it, I think that's going to look rather interesting to CMS because they assume this entire time we were reporting accurately. Do I think we could do a better job and use fewer of them and not just throw them around willy-nilly? Yes, they really should be the response of last resort. But we don't want to facilitate, we go from it's okay to use them to don't touch them with a 10-foot pole ever. Because I think the data shift is going to look odd. The other thing is, when we look at 1800s from outcomes perspective, the general feeling for most agencies has been my clinicians tend to underreport the problem. We want to make sure they're reporting accurately because reporting it accurately gives us a better chance to be able to show some degree of improvement. If you top me out at the beginning incorrectly, then I have nowhere to go. If we transfer that over to the GGs and looking at VBP, the idea that now scoring them lower is better is also problematic because right now our review teams, people are able to roll in home care independently way more often than not. Rolling is not a super complicated activity. I'm not worried about them hurting themselves. They roll, they're a 6. And now we're starting to see everybody in is now a 4 or worse. Wait a minute, nobody can roll now because of value-based purchasing. No one can sit up now because, well, they could before, but now we're like, they need to be worse. If the clinician was historically underreporting and needs to do a better job capturing the problem, by all means, they should be. But this idea now that no one can roll on their own, no one can sit up on their own because that's going to work out better in VBP, that's not how that calculation is intended to work. They're going to impugn a score at the end that could be the patient was a 6, and by discharge, we expect them to stay a 6. Based on the rest of your assessment, there's no reason they should lose that ability. And so by discharge, they need to stay the same. And if at discharge they stay the same, yay, you, positive outcome, you met the goal. So we got to kind of break the improvement is the only thing. And I think that's a huge positive of what they're changing with VBP.
And Cindy, I wanted to take the opportunity as I changed the slide to remind folks, a lot of folks we found out do not know that we outsource at K&K, which is kind of interesting because that is not how we started as a company in 2013. We moved into the outsourcing phase because we found the compliance in those spaces was severely lacking. And so if you're looking for a partner in compliance for your OASIS coding and plan of care, which we look at a little bit different, please reach out to us and set up a meeting. There's no obligation, and we can talk a little bit about your processes and see if we're the right solution for you. We are US based 100%. And Cindy and I are deeply involved in that aspect of our business besides the education. But I wanted to put this up here just to remind folks, we know folks are going through all their budgeting and things like that. And as we're going towards the holidays, Cindy, every year we put this out that if you need help at the holidays, reach out now. And it's not too late to reach out and get assistance if you have folks that are begging to get vacations or need to get a vacation and you're just worried about falling behind on work. Reach out to K&K and we may have a solution that'll fit you. We have 15 minutes left, Cindy, so I'm kind of going through the rest of these questions, and I wanted to hit on one here that really is kind of a big one for us. And it says, RN clinical manager is out, and for the life of me, I cannot find the regulation outlining medications have to be reviewed by an RN. I know I've seen it before, but I can't find it. For example, needing a meeting and to meet that for a PT start of care. So I'm going to let you take this one on because I know this is close and dear to your heart.
Well, some of you who've been on previous of these sessions are going to go, I know the answer to that one. We are not required through the conditions of participation to have an RN involved on a PT admission to oversee the medication review. How we got here, brief history lesson, is the COPs were updated and they did not say that a nurse had to be involved in therapy cases. They referenced, competency and all that other stuff, but they didn't say a nurse has to oversee it in the therapy case. Then the interpretive guidelines came out and they chose to put in the interpretive guidelines that yes, you do. Now that superseded the COP, and there was an immediate reaction to that from entities like the American Physical Therapy Association. The problem is that took a while. And then we had this thing, the pandemic, and a lot of that stuff getting updated got tabled because there were bigger issues that were going on. But we do know, not all that long ago, the interpretive guidelines were finally fixed to remove that piece because it never should have been there to begin with. Now, that being said, it's the technical what's right versus the operationally what's right. If you have had a model where nursing is actively involved in this and it's been working and everybody's happy with it, you are not compelled to change it. If your therapists have not been taking lead on this and you've had a nurse that does it, I would not say, hey, starting tomorrow, we've taken the nurse out of it. Good luck. Okay. You want to make sure that the people that are doing this know what they're doing, know what the expectations are. You have policies and procedures to support it. So if your policies and procedures say a nurse is involved, then you're going to have to amend that policy and procedure if you want to change the process. So if you're looking and looking and looking for something and can't find it, always check yourself and say, sometimes that means it doesn't exist or it doesn't exist anymore. And that's the case with the mandatory issue that an RN has to oversee the medications in a therapy case.
But once again, I would recommend to everyone to provide education to your clinicians. I know
Yes.
when I went to school in 1998, and there are those of you on this call potentially that weren't born then, that was an elective in my physical therapy assistant class load was a pharmacology class. It was not required. I believe there's some requirements in some of the CAPTE things going on with physical therapy now. Occupational and speech therapy, I'm not as familiar with, but I think it's super important that at the clinic level that you provide that real didactic education that can be used and set policies that folks know at what point do I call an expert. Because you even have in your nursing corps, you have those that are better with medications than not. And you have those with more experience than not. So I think putting it in a decision tree type of situation when it comes to medications is never a bad idea.
Well, I think, Sherry, it has to do with a lot of those tasks. Well, I think sometimes, we look at a particular discipline and it's like, well, obviously they may have had more training in this, or naturally that's what defaults to them. So, I don't really have to worry about it. But we also got to think about, in talking with agencies, the days of, my new hires overwhelmingly have home health experience before they get to me are over. It is, I can't wait for a fully trained, experienced home health nurse to show up. I'm hiring out of skilled nursing facilities, out of hospitals. I've got new grads. I'm trying to mentor those. I think it also is a check to say, how well do they understand what those expectations are in this setting around medication management? That it's not just, what do we put in the computer and what comes out the other side, but that where are they kept, what's impeding them from right dose, right time, things that they don't really even think about in the hospital because, when it's time for your medicine, here they come with the little cup on the tray. And at home, we know full well nobody's showing up with the cup on the tray. And they forgot because they were too busy watching their favorite soap opera. I mean, those are issues that complicate this that someone who's never been in this setting may not instinctively know. So I think to your point of, training and assessing and looking, I think, given the way staffing has shifted away from experienced people in this setting, we don't ever want to assume that this just immediately translates over and there's areas I don't need to think about.
And I think that this is where we can make the case for that focused education that comes in shorter bursts, Cindy.
Yeah.
I think that, the days are gone. Everyone on this call that's my age or older, you're going to collectively gasp, but the days are gone of the 90-minute webinar being something that the attention span of the next generation will listen to in a fruitful way. And was that kind the way I said that? It's just a different generation. They consume their knowledge or they consume info differently than we do, and they need it in shorter, more directed bursts because they will lose their concentration and lose the message along with that. So that's something that K&K has done. We have absolutely designed our education to meet the needs of the next generation and to be portable. And that's so important as folks are riding around in the cars. There's all this dead time that they could be listening to some really directed education that could help them on their day to day. So look for that types of education. Look for those things that are going to engage your staff in a very, very fruitful way, and that you can gain that knowledge over time, because it's not going to happen in an hour and a half. It's just not. And
before we go to the next question, though, Sherry, I do want to highlight what we're seeing in the chat box is, yes, you do need to check state licensure requirements. There are some states that, when you get into the specific practice act of the therapy discipline, may have something specifically stating what needs to occur with this, or what they're able or not able to do. To that end, though, I just want to remind folks that a practice act being silent does not mean, oh, I can't do that. You want to check those practice acts, but sometimes if it's something I don't want to do and my practice act doesn't say anything, and me saying, well, that means I can't. Oh, but if it's something I do want to do and it doesn't say it, so that means I can. I just want to make sure what's really in there versus what we may have been told or interpreted is in there. But yes, if we do find licensure or practice act issues in our state that supersede it, obviously we do need to adhere to that, because we could find ourselves in other issues.
Absolutely. Okay, so our next question is completely a change of conversation, but then we want to end with the new COP. So don't go anywhere, guys. We got this new COP coming. Can you provide an example when introducing a new device would not be considered an intervention or skilled care? In regards to GG items guidance that states it should not automatically be considered intervention, meaning that you can, if not considered an intervention, use the level of assistance needed with the new device as a start of care score. We could not think of one.
Okay. What we have to consider with that is, what they're basically trying to say is that because they have a new piece of equipment, you're not immediately penalizing them with respect to choosing those answers. So you wouldn't go in and say, oh, you just got that walker? Well, I'm taking that away from you. Let's see how you do without it. But the issue is more of, okay, are they using that new piece of equipment correctly? So it's not about how long they've had it, but how well are they using it? So I could get out to the home, and we know that the bathing items in GG, they're not swayed by having equipment. We know GGs say that with or without equipment is irrelevant. But if I got out there and, yeah, you got that transfer bench delivered yesterday, well, I don't automatically discount that. But if I go in there and it's all set up wrong, and it's in the tub wrong, and it's all messed up, then I am going to have to do some sort of intervention to fix it. And we have to remember that when we're baselining individuals, whether it's function, med management, whatever, we are choosing responses of what they were doing before we got there. Before we open our mouth, before we rearrange something, before we change it, before we adjust its height, before we do any of it. Or in other words, what would they have continued to do if you didn't come that day? And this is where, this is not a gaming strategy. It's about, sometimes we something, we jump in there, we fix it, and then we choose a response that says, look how good you are. Well, they're only that good because you changed the game by doing something. Now, I've had people, Sherry, say, Cindy Krafft says, don't do any interventions on that. That is not what I said. It's being aware of, if I have to engage with that equipment and I change that dynamic, so it changed how you use it and now it's safe, well, then it wasn't safe when I got here, which is why I jumped in. And the true answer is, what was their safe level of performance without me? Sherry, I do want to touch, before we do the COP question, because we have a theme of questions, and I think I can pull it all into one, because we also had one typed in today.
Okay.
And that is interpreting an activity not attempted code. So the patient, I go to do an activity, let's just say I'm going to go 150 feet. The patient gets to 100 feet and I'm tired. So what do I put? Do I say that they didn't do it? What do I do with that? I'm trying to avoid the ANAs whenever possible. And the manual does talk about clinical judgment. It does talk about talking to the patient. It does talk about, looking at a bigger picture, not just an arbitrary bang, you didn't do it, it's automatically an ANA. I want us to be cautious here, because what it's saying is, if I look at that situation and I went to do this task and we got most of the way through it and they weren't able to finish it, And I'm hearing from the patient, and I believe them, that, oh, earlier today I did that. And the daughter says, oh, yeah, I walked him all the way over there, which you look and go, that's about 200 feet. I took him there this morning. He did pretty well with that. Okay. So now I know he did walk earlier with the daughter, and I believe she's reliable based on the assessment. Then I do have the opportunity to infer an answer other than the activity not attempted. But I would also say, just because it says I can listen to other people, if I got that person who I was going to 150 feet to 100 and they are exhausted, they are done, there is no way, and I'm looking at them, there's no way they can finish this. They cannot do 150 feet. And I'm talking to, there's no daughter, there's nobody else. I'm looking at this. I look at the therapy notes from the hospital, and 75 feet was the most they ever did. I'd be hesitant to turn around and use anything other than an ANA, because clearly this person does not have the capacity to get that task completed. And the instructions about ANAs are clear. If they cannot complete the task, and I've talked to the patient and I've looked at the medical record and I've talked to their caregivers and I'm using my clinical judgment and I'm like, there's no way this person can do this, then I'm going to an ANA. So I just want to caution, yes, it talks about collaboration and other resources, but through the lens of clinical judgment. We already have this problem. GG's aside, when people say, I live alone and I took a shower by myself. Okay, good for you. That scared me to death. I am not putting down your independent just because you said you can do it. So we want to use that same lens. Sherry, I know this probably will push us over a couple minutes. I'll be concise.
I'm going to
But
change to our informational slide, Cindy, so
okay.
people have a chance to see our emails if they need to reach out, and to know that our next session will be January 3rd, 2025, where we'll be 23 days into the new OASIS. So go ahead, Cindy, about the new COP.
Well, I know there's anxiety about what went into the final rule about the new COP, about having to publicly disclose what services we have. And it's not just the six that are part of the home health benefit. It's not just listing those six. It is also listing any issues within those. So let's say I have nursing, but I do not provide psychiatric nursing. We need to make that publicly accessible. And that is not covered by what is currently on Home Health Compare. That just lists the six services. We also had it confirmed just this week that that also means if your agency does not provide maintenance therapy, yeah, you may have PT, OT, and speech, but you don't provide maintenance therapy, that is also expected to be disclosed. If you have a staffing issue that's going to delay the onset, yes, we have OT, but you can't get it for 2 weeks. They expect that to all be publicly disclosed. Now, it says the parameters of, frequency problems or whatever, updated annually. What we do know is it goes into effect January 1, 2025. What we don't currently have are the interpretive guidelines. And we mentioned earlier what happened with the med ones. The COP said one thing, the interpretive guidelines went a little further, and we ended up with some issues. So the challenge is the response to when are the interpretive guidelines coming out from CMS is soon. No dates, soon. But that does not change the fact that this thing goes into effect January 1, 2025. So we can't wait for the interpretive guidelines to do this. What we did this week, and Sherry, I don't know if they can just email us through this slide, but we just did a podcast with Mary Carr from what is now the Alliance, what was the National Association of Home Care and Hospice coming all together. But she did a great job on a podcast for us talking about the COP. So that's free. It's on our YouTube channel. If you want to take a listen to what she had to say about it, but I think the key point that she hit is this is really being done to help referral sources. Because what they're saying is, I can't find agencies. I'm calling this one, they tell me they don't have that. This one, they don't have that. Or I picked a home health agency, then the patient started with them and then finds out they don't have OT for 3 weeks. They don't have a speech pathologist and they can't provide an aid, which is like, you really should have said that before you took them, not after. So for me, reframing it as this is meant to be publicly accessible to referral sources and potential patients so that they know upfront what you may not have, I think is it reframes it differently as opposed to, oh gosh, this is just busy work to humor them. But yes, the key thing we're waiting on is the interpretive guidelines to expand potentially some of those details. But we do have to have a policy in place and publicly accessible up and running by January 1st. But that podcast, I think, can be very helpful. And I thought, Sherry, that Mary gave us some really good thoughts on that about key takeaways and kind of how we ended up with this COP situation to begin with.
And what you should be doing now as a result of that. I thought it was
Yep.
first of all, it was a coup for us. So honored to have Mary on one of our unfiltereds, and we poked the bear a little bit, and she was a lot of fun. So I hope y'all enjoy that podcast. Cindy, did you have any further information as we close out our last one of these for 2024 and plan on seeing everyone in January?
Well, I just want to thank people for their engagement with this. I think the questions are good questions. I think for those of you participating, it either makes you think a little bit or validates something you're already doing or prompts a question in the box, which I always find interesting. I look forward to what we're going to continue to discuss in 2025. Thanks to CMS, there is never a dull moment in this place. And as far as the E1 transition, we're not blowing smoke. These are minor changes. It is one new question, two modified questions, two completely removed questions that didn't need to be there anymore. The GG goals column makes sense, and we need to revisit GGs anyway. So the drama of you need to go to 12 hours of training to be ready, I don't think so. So I wish everyone as peaceful of a holiday season as is possible in the home health space. I know that's sometimes difficult, but thank you for sharing some of your day with us.
Thanks, everyone, and please be safe out there. The work you do is wonderful, and just always know that. And thanks again for participating. We'll see you soon.